Hello everyone, my name is Emmanuel Shafiq. I will be doing this presentation for maternal and child health GPH 738. My topic of choice was maternal mortality and women of color, specifically because I'm doing a second degree at New York City, and I work in Harlem, and I see that minorities in general are they have a much larger burden to overcome. And I thought this was a very good topic to dive into, especially for me as a male, to understand what these women are going through and what I can do from um, my perspective to help and to learn more about this issue. So let's get started. So, women of color maternal mortality. So black women are actually 3 times more likely to die from a pregnancy-related cause than white women in the United States. There's variations in healthcare quality. There's underlying chronic diseases that can be managed differently. There's institutional racism and bias to all variables that make this inequality happen. And these gaps are going to caused by discrimination, which results in income disparity and residential segregation as a result of long-standing systemic racism, especially in hospitals, depending on what the hospital is. If the hospital is in a very underfunded area, they're not going to be able to take care of the women and their children and the pregnant women, as well as a well-funded area. And that all depends on the makeup of the community and the funding of the community, as well as the income of the individuals that make up that community. So it is a side note that if you look to the right, that the pregnancy-related death race by ethnicity from 2007 to 2016, which was only 5-6 years ago, black women had 40.8 pregnancy-related death rate per 100,000, as opposed to white women at 12.7. Hispanics are about the same, and that's a very large discrepancy and a very large number. So for black women and AIN women, disparities in pregnancy-related fatalities grow with maternal age and persist throughout their educational levels. It should be noted that it's been shown that black women who have a higher education, college or postgraduate, still have a higher risk of having a higher mortality rate than women who have just completed high school. And that's saying that education is not helping or assisting these women. It's something's happening beyond that. The racial gaps remain at all levels of schooling, which I just mentioned. In comparison to white women, black women with a college education or higher had a 5-fold greater degree of pregnancy-related death. That's a huge number. Pregnancy-related mortality is 1.6 times greater for black women with a bachelor's degree or higher than is for white women with only a high school diploma. Cardiovascular disease is the main cause of pregnancy-related death among the women in general, and cardiovascular disease is prominent against African Americans, but that shouldn't be an issue of why these women have a higher rate. They're emphasizing the relevance of chronic disease management and pregnancy outcomes. There are certain risk factors that are common among black women. Like I said, cardiovascular disease is one, which leads to infant mortality and can have a long-term effects for the children and physical and cognitive health. But at this point in 2022 or 2021, we should be able to have a balance. It shouldn't be a factor amongst these women. So what causes this disparity? So before we talk about pregnancy, it's vital to talk about the variables that lead up to it. And one of the first things to mention is contraception. Contraception is more readily available to well-off communities and less perceived as an issue than in lower communities. For example, the Plan B pill goes for around an estimate of $45 to $55 per pill. That may seem like a small number to a middle-class family, or an adequate number to purchase something like that. But for a low-income family that makes $30,000 a year, $50 is lunch for the week, and you can't really spend that. If provided quality treatment and access to information, several of these health issues can be reduced or prevented. and the historical backdrop of racism is at the top of the pyramid or the circle, and it has an unintended impact to all the lower levels. So if we see on the picture on the right, the mother and the family are at the center, and again, that goes to how well the mother and the family are being taken care of, how well is their nutrition being managed, how well are they able to have financial stability. The community and society is how the community is affecting the mother and the woman. If the community and the society around a low SES community is not going to aid the mother and the family, the mother and the child may have will have a higher issue when it comes to nutrition, growth, stability, and issues like that. Healthcare system factors. Women of color are less likely to have insurance, and if postpartum depression is a big issue. If the woman's not insured, or let's go back a step further, the woman has to pay out of pocket for birth. That's a big gap. That's going to be a big issue, and if there's no insurance and there's women of color aren't insured as often, which again goes back to the historical context of racism, which is the outer circle. That's going to affect everything inside the circle, and it's a snowball effect. Racism is going to lead to the woman and the child not having health care insurance, and they're going to not be able to pay for their insurance and not be able to see their doctor, which is going to cause them to have more issues, and they're going to continue, and it's going to go on for generations and generations. A quote by Walensky in his paper of 2018 that internalized racism is characterized as the acceptance of negative messages about one's own talents and intrinsic values by members of stigmatized races. So a good example that was mentioned was teen pregnancy. An African American who gets pregnant at 16 might say, "Oh, this was expected." Meanwhile, a white woman of the same age might say, "Oh, I did a mistake." So internalized racism begins to become something that becomes personified, and it must be dealt with and removed. Internalized racism is thought to be learned and can be unlearned through the formation of racial identity, right? So if I'm the physician, I'm prescribing or I'm checking on a young female patient, and I see her being of color, I will say, "Oh, it's the way she was brought up," which is not the case. It has to be the physician and the individual have to have a caring that mistakes happen, and they have to have growth in between the individual and the physician. Prenatal education programs are declining, and more women are having high-risk complex pregnancies. Yes, this was true in a paper published by Gorillo 2021 that prenatal education programs are actually declining in in urban areas. I apologize, not rural areas. And it's having an effect where women are having high-risk complex pregnancies because they're just having unprotected sex. They're having they're not be able to get the contraception and issues as such. Traditional postpartum care consists of daily hospital visits for 2 to 4 days and 6 weeks follow-up appointment with a provider. Again, if you don't have insurance, or the woman has to go back to deal with other issues at home, she might not come back for this visit, and that's a big issue. Postpartum depression is a big issue, and other nations besides the United States have coverage for this, but we do not. Health conditions and mental health are the most important things to focus on for the mother. Possible solutions include giving pregnant mental health courses, counseling, education, and health disorders that are risky during pregnancy, and appropriate stress outlets. Postpartum evaluations. So how do we evaluate? Well, we can give within the first 3 weeks of mother. We can assist at address concerns concerning postpartum outcomes. We can follow up treatment that should be offered, as well as last postpartum visit no later than 12 weeks after birth. We can do home health visits. And minimize the risk of postpartum problems, particularly for women who may face challenges with social support, transportation, or maternity leave, which women of low SES will have these issues. And then how do we evaluate? We do a goal, we set it up, we plan for it, and we see that monitoring, implementation, surveillance, these are what the current health indicators are. We evaluate to see that we reached our goal, and then what the outcomes are and what the next phase of the project is going to be. So you create a logic model, you define the acceptable delivery, you formulate the questions, determine the methods, and put the planning in context, and finally you find the plan in consultation with relevant stakeholders. So you say this work did not work with the stakeholders. You can do it by having data. How many women are succeeding, how many women are not succeeding, how many women are coming back for treatment, how many women are going to these prenatal healthcare seminars, issues like that. You can do logs, observation checklists, medication, such as the Plan B bill to see if it's working, using variables like participants' responses to see if they're happy with what's going on, mediators, unintended effects, and quantitative indicators evaluating mechanisms of impact focused on how intervention activities on participants' interaction with them generated change. So we want to see what the issue is, what we implemented, and how do you evaluate this issue. Some issues that do happen that it will take barriers that will happen. You will have to be overcome over long periods of time. Is low SES. SES can change within a generation, but sometimes it takes multiple generations to overcome. So if we're tackling this maternal health of women of color, we have to tackle the low SES seen in women of color. Besides the inherent racism that's seen, so we have to be able to say what can we do to raise the SCS level of young women of color to see that they're on the same level as their more privileged counterparts. Insufficient knowledge. So maybe the maternal health service among rural or urban migrant women of rural communities, women in places such as Harlem. There's multiple other problems going on besides maternal health. So maybe the issue of maternal health needs to be addressed and advised. So the logic model that I picked out was nutrition. The resource that I would like to do is nutrition, delivery practice, family planning. And nutrition, for example, in New York City is done through WIC, which is the WIC program, and they give vouchers to allow women to go and have better options for food, where they're only given for milk, dairy products, meats, stuff that will be beneficial to the child and the mother. And the short term is it'll give a woman and the child something to eat right away. Midterm, the meal selection will be better and better increased practices. And the long term will be decreased maternal mortality. Delivery practices, more women are not able to go to the hospital. Maybe they don't have insurance or they don't have it won't be covered. So you can do more doulas in the community. You can increase the knowledge of the hospital-assisted births outside of the community, of non-hospital-assisted births outside the community. And the midterm outcome, mothers may be likely to give birth at the hospitals, or they may want to give birth with the doulas, but they will have more knowledge of where to give birth, and this will decrease maternal mortality amongst women. Family planning, you can fund for contraception and other issues. You can decrease need to have child. There's sex practices and may postpone childbearing, and long term we have better family planning and so on. This is my bibliography. Thank you so much, and have a great one.